First of all, I want to thanks to the authority of Neurodiab and principally to my friend, Professor Ariel Odriozola. My talk is Charcot food, and we have to speak about if we can avoid deformities. This Charcot food is an arthropathy. It's a painless, progressive, and degenerative progress affective single or multiple joints due underlying neurologic defects. This is my group, my team with traumatologists, vascular surgeons, diabetologists, infectologists, and nurses. My hospital, the most important etiology of Charcot food is diabetes, but you have to think other etiologies. Charcot food, the first publication was in Archives of Neurology in the past 1883. The prevalence in diabetic food clinics is approximately 13%, and the incidence 0.1, 16%. Charcot food increase the risk for food ulceration, bilateral disease, or major amputation. There are three theories, actually, neurovascular, inflammatory, or neurotraumatics, that leads to destruction of bone. Bone is with osteopenia, osteoporosis, and destruction, subluxation, and really severe deformities. Early diagnosis is very, very important because delay is usually when you see a food inflamed neuropathy and diabetes is equally Charcot until shown not to be. Again, early diagnosis is important. The diagnosis of the Charcot is usually delayed. Look this paper in approximately 400 non-diabetes specialist physicians in a university teaching center, 67 admitted poor or no knowledge about Charcot food. Be aware of this disease if you see a warm food deformity without lesions, with pulse present, antecedent of trauma, difference of 2 degrees between both limbs. You have to make the diagnosis differential between cellulitis, osteomyelitis, arthritis, thrombophlebitis. If any doubt, please offload the patient, because lack of diagnosis leads to deformations, recurrent ulcers, inability hospitalizations, use of excessive drugs, antibiotics, MRIs, and scans. Use to the diagnosis differential to see the difference temperature with the personal dermal thermometry. Charcot food has 2 stages, acute and chronic stage. The acute stage is a hot swollen neuropathic food with edema, and 2 degrees hotter limb with contralateral food affected with in the midfoot and a fast progressive destruction. In contrast, in the chronic stage, when you see a swollen neuropathic foot with the edema persist and appear the joint deformity, subluxation, dislocation, the longitudinal arch collapse, and the rocker bottom deformity. You can see when you see the acute stage, please offload with Walker or cast. Here is the classification of Dr. Brodsky. The most common is the type 1 in the midfoot. MRI is sensitive, but not specific versus osteomyelitis. Here you can see osteomyelitis of one bone in the left and Charcot foot on the right. We need to do the early diagnosis of Charcot foot in the stage of grade 0 with low severity with mild inflammation, no deformity, X-ray normal, and when you see an X-ray normal, you suspect Charcot, apply an MRI when you can see edema. In contrast, when you have a grade 1 and you can see deformity, X-ray abnormal with MRI abnormal also. Again, early findings are clear in MRI with marrow edema, trabecular fractures. MRI has difficulty in distinguish Charcot versus osteomyelitis. Charcot foot is located in the midfoot with multiple bones or joints. Deformity is common. Osteomyelitis is affected forefoot, generally one bone. Deformity is rare, but there is often direct extension visible. Again, Charcot foot is terrible, leads to reduced mobility, reduced quality of life, leads to amputation, and of course, reduced life expectancy. Here is an algorithm of the Foot International, which is the suspect of Charcot. When you see a red, hot, and swollen foot, please suspect. You can see in the X-ray positive, you have to offload. And if you see negative, please apply a MRI. And if it's negative, perhaps Charcot is negative. Summary: high index of suspicion in Charcot is edema, warmth, neuropathy, abundant pulses, and trauma. Use appropriate imaging techniques. What? X-ray and MRI. Please, non-weight bearing, recommended. Cast and Walker provide protected ambulation and periodic evaluation. Which are the general treatment goals? Convert from active to inactive situation. Prevent deformity. Provide protected ambulation. Prevent recurrent ulcerations and instability. And which is the natural Charcot foot? First of all, the acute Charcot, we can avoid the deformity and untractable when you put the patient in offload, because deformity and Charcot, you have to lead the patient to an amputation or to surgery, because look, the final stage really is terrible for the patient. Look at this deformity, or to this final stage with this deformity and these fractures with no solution. This is my final, and please think about Charcot, and we can avoid with offload and think disease in the stage 0 and 1. Again, thank to my friend Professor Ariel Odriozola and Neuropatia. Thank you.